There we go. Okay, so we're going to start with a conversation around ED throughput. And I have a poll that I'm going to run. What we'd really love to know is, how do you measure your ED throughput? Is it looking at the time spent for a patient waiting to be seen, your time of arrival to time of departure or discharge, arrival to diagnosis, other, or all of the above? You kind of look at all those different elements of the patient experience or the patient throughput in your emergency department. I'll give just a couple more seconds for responses in the poll. Okay. So sharing the results, we'll see that most hospitals are looking at time of arrival to time of departure or discharge. This aligns with that outpatient quality reporting measure for the MBQ-IP program for rural hospitals of OP18. And then also a good chunk is looking at wait time and a variety of all of the above. So thank you so much for sharing. That helps us look at and define what we mean by ED throughput. So the national median for our time of arrival to departure for discharge patients in 2022 was 115 minutes for critical access hospitals. And this can vary depending on what they're being seen for, who's on staff, etc. But that's just a tidbit of information. The question I want to pose is, what is an appropriate ED throughput time in your eyes? And what might be barriers to meeting these times? And again, please unmute or share in the chat box.
Hi, Jen. Sometimes ours is finding transportation or medical clearance, waiting for ABGs or alcohol levels for safety for discharge.
Thank you so much, Christy. That's a great perspective. I didn't even think about those pieces. And Rachel commented, transportation is a challenge. Amber, your hand is raised. Go ahead and unmute.
Also, we have like certain physicians that are faster than others. And if you have this combo of like two of the slower producing ones, you'll see a big difference in that time.
Awesome, thank you. That makes sense. Some physicians just spend a little more time. Mandy says we have issues with radiology read times and issues getting beds when transfer is necessary. Is there any other kind of barriers that you've seen with bringing your patients through the emergency department in a timely fashion? Amber, radiology read times is huge too. Yep.
Consults, waiting for outside consults, phone connections, or timing of those appointments. CRT.
Thanks, Christy. Sheer volume, more than the staffing. So there's so much that really is not related to the patient care. It's just timing, natural timing of things. In Danielle's facility, they're having a higher than ever census through the ED. And so they have to think about staffing with that, with having only one provider per day at this time. So has anyone had any successes in overcoming some of these barriers? Have you tried any different processes or ways to help remove some of the barriers or make things more efficient?
Jennifer,
So I see some comments on volume and busyness. So have you looked at different ways to do triage that might, or different staff to do triage that might improve the efficiency or the timeliness in getting through that piece? Yes, Amber.
we have initiated this year, we initiated a triage nurse, which has really helped us. We also had some nurse initiated standing orders, but we've really revamped them and made them more extensive. So that we can get things going faster, so that by the time the doctor sees them, we've done most of the stuff that we would know that the doctor was going to do.
Awesome.
We're giving tramadol, we're giving IV Tylenol, there's a lot of medications too that we've added to our nurse initiated standing orders.
That's a great idea, trying to get what can be done before they see the provider done, so that makes that go more quickly. So is there any facilities, radiology retimes was a huge thing also that we've heard. Is there any facilities that don't have a barrier here that might want to share what they do that has helped make those times more effective? Anya commented that we track and report out radiology read times and give direct feedback to the reading radiologist, but we still have a barrier here. So my quality improvement hat, I know this isn't a call for me to solve problems, but it makes me think of how we can engage the radiology providers and the radiologists into their why. Like, why is this so important for the patient in a way that they can relate to? It's that speaking to the heart of the matter helps build us engagement. So maybe there's different things that our radiology staff are more in tune to that we can talk to them about to help them understand why it is so important from their perspective also.
I think being in a very rural area, it's hard because the radiologists that are here are they want to retire, so they're wanting just a few days and or a few hours here and there, and we're pretty desperate, so we've got to take what they can give us, kind of thing, and then send out our reads after when they're not available.
Right, so you have limited time with on-site radiologists to begin with. Thank you, Amber. Does anyone else have any insights on their challenges or successes in looking at the time from the patient in their waiting room or the time from arrival to discharge, and that we've improved, or that are still barriers that we haven't already talked about? Well, thank you guys so much for sharing on ED throughput. If anything comes up, please feel free to throw it in the chat or shoot me an email afterwards. We are using this feedback to help kind of update and redesign some emergency department improvement resources that we have, and put in these sharings of ideas that others have done, and common barriers as well. So the next topic we have on this is inaccurate diagnosis. And this comes because there's been some studies that have come out that have shown that inaccurate diagnosis in the ED is relatively high, around 5.7%. As a caveat, though, I will say that this is all hospitals and it's not stratified by rural and urban. So there are maybe some hospital volume and size and settings that can influence this, but this is the data that we have so far. There are 5 conditions that are most common to have an inaccurate diagnosis in the ED. The first is stroke, the second is myocardial infarction, the third is an aortic aneurysm or dissection, the fourth is a spinal cord compression or injury, and the fifth is a venous thromboembolism. And I probably butchered pronouncing that, but y'all know what I mean. Anyway, so we know that these inaccuracies aren't because providers don't want to care for patients, but it just means there's something in our systems and in our processes that are influencing it. And we'd love your feedback if you've had any experience or seen this come up in your emergency department where there's been maybe some inaccurate diagnosis. On our last call, we heard that most of the hospitals on the call haven't really seen this as a problem in their emergency departments. Is that a fair assessment for this group? I'm getting some yes, not too common. And so anyone that has had any, I know most of them are not too common. So can you think of any factors that might have contributed to it? We've heard in other conversations and settings that sometimes insurance can play into it, availability, maybe telehealth providers, some implicit bias. One patient and family caregiver that I talked with talked about the inequities of going in and being of an older generation, and some providers just making assumptions based on age. And this can be true on the flip side too, also for a younger patient. So what I'm seeing, there's really not, it's not really an issue with this group, and that's fantastic. But if you think of anything or have some insight of your own perspective, it's not an issue in your hospital, but from your own experience of any factors that might have influenced something, an inaccurate diagnosis in the ED, we'd love to hear it. Amber has a great comment, maybe communication with foreign language speakers. We've seen that not just in patients that English isn't a primary language, but maybe your provider doesn't speak English as their primary language. So there can be some back and forth barriers there that influence the interpretation of what each other's saying. That's a great perspective. Thank you, Amber. So since this isn't an issue, we're not going to spend any more time on it. Again, please reach out to me via the chat or via email. I'll give you my email at the end today. If anything comes up to your mind, because we are really collecting what we can to help harness everyone's lived experience in their hospitals to provide as holistic and overarching concepts and ideas so that we can share with you all. So the next segment that we've identified as a possible influence of patient care and safety and experience in the ED is transitions of care. This is a difficult piece of the healthcare experience, no matter what service area we are in. So I would love to hear what have been your experiences with patient transitions from the emergency department to either home or other care settings. And these might be really similar to some of the throughput barriers as well. Yes, Amber.
Well, a lot of times there'll be, our population is very elderly, and I think there's a lot of confusion when they leave, maybe unclear, or maybe we need to present things differently, but they will call. We do have an ED navigator in our emergency department that kind of helps with orders and getting people set up for, follow-up visits and stuff. But if patients don't get a call right away from their other physicians or facilities, they'll call the navigator, frequently upset. So there is sometimes you can find that there are gaps between here and the facility that we're referring them to, whether they're receiving those orders or not, or they're not getting them scheduled for a visit in a timely fashion. That has been an issue for our facilities and our other specialty care facilities.
But what a great resource that the patients know they have to go to. And it also helps provide the hospital with information on issues that you might not have known were out there.
Really, I don't know what we would do with our population so elderly. I can imagine them not following up if we didn't closely follow up with them and call them at home and make sure this is going on. A lot of times when we do, they are confused about what they're supposed to be doing.
Yeah. And I think it's smart to remember that when we have patients leaving the emergency department or any other care setting, they're not feeling good and they're kind of stressed and overwhelmed. So it's really normal and to be expected that there's confusion, especially if they're on different medications or if they're older. I know sometimes, I'm in my 40s, I have a problem navigating healthcare, navigating my kid's high school, just because has changed and is new to me. But I think having that follow-up from the hospital after the ED visit is so incredible. Thank you for sharing that, Amber. And Erin shared in the chat that they've created a standard handoff tool for nursing to use between departments to ensure that the report and handoff call covers all high importance topics. Erin, is that handoff tool something you'd be willing to share with others that we can show as a resource designed from a hospital? Awesome, thank you.
Jennifer, is this just from ED leaving the emergency department, or is this also include people that are being admitted upstairs?
It can be being admitted into another part of the hospital as well. So any transition out of the ED, whether it's to home or it's to inpatient or it's to another care setting.
We've had issues with sepsis, which is always an issue everywhere, it seems like, but with how much fluid for the receiving floor to kind of know where we're at, and how long they need to be doing the vital signs to make sure that our therapy or what we've given them is working. They don't need to initiate vasopressors or anything. This has kind of been an issue that keeps coming up with us. We developed a form that tells the receiving nurse how much fluid has been given, so how much is left for them to give, and whether they've received antibiotics. They'll kind of know where they are in the sepsis process to know how often they need to be checking their vital signs and reassessing whether they're needing pressors or not, to help with that. But there is still the buy-in from the nurses on using that tool. I wouldn't say they're all using the tool.
Well, it sounds like an amazing tool. Would you be willing to share that with us? We'd love to, because I think that communication is huge, not just for when we're talking about ED transitions, but in sepsis treatment where everyone's really struggling. Thank you. That's a great thing to identify as something that needs a specific condition that needs a little more information as we're transferring or transitioning. Does anyone else have any experiences, challenges, or successes in transitions from the emergency department? Yes, Amber.
I feel like I'm hogging this meeting, but
No, you're saving me. I love it. Thank you so much. I appreciate you being so open to share.
we've also had issues with behavioral health patients. I mean, we don't have the resources that we had. And honestly, there's always been not enough resources for behavioral health, but we've been having a lot of changes with that. And it takes, a while to get acceptance. And that is a challenge, a constant challenge. We just don't have enough resources for them. So they end up staying longer than you want. And they're not receiving the care that they need while they're here.
Right, exactly. Thank you. Amanda.
Hi, it took me a minute to find the raised hand icon, but by the time I did, I was going to add that the psychiatric emergencies are also what impact our ED, because if they are emergency detention, then we do have to use specialized transportation. And because a lot of the psychiatric hospitals are outside of the area that law enforcement would do the transport. So we have to rely on this specialized transport, and it sometimes takes them a while to get here because of their limited resources. It could sometimes take up, to 90 to 120 minutes for that transport to get here. And so those psychiatric emergencies in our ER that long tend to utilize a lot of resources. Yeah. And then, in a small setting, it can be intimidating to other patients in the ER. And so sometimes that contributes to patients leaving without being seen or against medical advice.
Absolutely. That feeling of safety.
Yep.
Yeah. And, we talk about like psychiatric and behavioral health patients. To me, being someone that has really high anxiety and having a son that has high anxiety, when you're in a state like that, it's like you go to the hospital, you need pain, you need something like pain medication, but they can't give you the right kind of pain medication. It's like sitting there with a broken leg at a psychiatrist's office. They can't treat it. And it's really uncomfortable and really painful. Has any hospitals been able to overcome this across the board struggle or barrier with getting timely behavioral health support and resources for patients, whether it be resources within your own hospital or partnering with community members, any collaborations, that kind of thing? We'd love to hear. Yes, Amber.
We've implemented peers in our hospital, and they have been so amazing because they really are there to listen to the patient, to connect with the patient. And nursing in the emergency department, I mean, we're just not that, I don't want to say we're not empathetic, because we are. It's just that we have other things we've got to do, and you kind of triage them as the last person on, when I get a few minutes, and they don't get that their needs dealt with. And the peers that we have had have been so amazing. They've also been amazing with some of our hospital transformation quality improvement stuff that we're doing. They've been doing screenings that we just have not been able to do, that the nurses have been not, fulfilling. And we've tried, the peers have taken over, like a screening for depression and mental health screening for like even the pregnant women.
Yeah.
And there's doing screenings. They're also working on our Narcan program for opioids. So we found a really big use for them with our behavioral health patients, but also helping us to meet these measures that we're supposed to be meeting for reimbursement.
Absolutely. Can you say more about the staffing structure for your peers? Is there a certain education or experience you're looking for? Kind of what do those staff members look like if others are interested in exploring this?
They do have, now we have a behavioral health director that we've also, that's a new thing for us in the last year and a half probably. And he's kind of taken this on and gotten the peers, and it's been amazing for our behavioral health population. But they have to have a lived experience, and that really helps them connect with patients. But they also have to then go and get, there's certain education that they need to get, and certifications that they follow up with and have as well. But they do our patients love them, and we love them too. So it's been great. Not quite sure what all the certifications are, but I could find that information out for you. I've heard other people that are getting peers that it's been a huge resource.
That would be amazing, Amber, because I think the more unique ways we can look at this and the more ways we can harness some resources and people to make things more comprehensive and to help with that transition, the better. So thank you so much for sharing that. Do we have anyone else on our call today that would like to share anything on ED care transitions? Are there any other barriers to patient care, safety, and experience in the ED that don't really fit into one of these categories that we might have that might be in our blind spot here? Yes, Amber.
I have to tell you what's really on my mind and what's a big issue with us, and I just see it getting worse. I can't help but think this wouldn't be an issue with everyone here, but it's violent patients. It's becoming bigger and bigger, and it's more frequent. And, I'll get other ancillary staff, their managers will be like, they don't want them to come over and put them in that position. but we have to put our nurses in those positions. We have to be in those positions. And it's about at what point, we have to do everything for them. There is no legal, okay, at some point it's so unsafe, you go on an EMS ride and they go to a person's house, they clear the scene first to make sure it's safe. We can't make sure it's safe before we give these patients care. And I really, really worry about where this is going. I don't really have an answer for that. We do have our security group that we work with. He is doing some ALICE training and he's going to really train us. I want to do de-escalation training, but also like true defense fighting, not the silly stuff, but real stuff. And just equip my staff as much as I can. But I feel like there has to be something else. Like we really feel like a big dumping ground from the PD and sheriffs. We had a situation where 5 officers came in for this one guy and then they just leave him, and you needed 5 officers, but you're left them with my small little female nurse in there, So I think this is a huge issue. I think it's getting worse, and I would be interested to hear how other emergency departments are dealing with this or what other ideas they have.
Absolutely. Who else has dealt with this that can either share some ideas or commiserate with Amber? And I know I have, and I'm sorry to put you on the spot, Helen, but help my colleague Helen Craigie, who's been doing a ton of work with workplace violence and workplace safety. I know she's on the call. If Helen, you want to share anything while folks are thinking.
I'm sorry, no, it's a great question. Sorry, no, I don't really know how to address it. What comes to mind though is I know we keep hearing about like staffing shortages, and I hear, they have, a lack of this type of expertise at this type of time, or like really trying to, I don't know, figure out how to use a team properly. I don't know. Sorry, no, you caught me off guard.
I know. I'm sorry.
Let me think more. I'll add into the discussion, but no, this is a really great conversation.
So I had seen someone else unmute. So does anyone else have anything to share on the topic?
Hi, I just wanted to share our hospital. We have a large psychiatric population, and our hospital just recently has formed a task force with different shareholders in the hospital to identify these patients. And if, there is patients that are acting out in the ER, or they're aggressive or whatnot, our task force is working on getting a screening tool that can be completed in the emergency department to be passed on to, it gets passed on to the other departments the patient goes to increase awareness so that workplace violence doesn't happen. I don't know if it'll work or not, but we did develop a task force to look at all of these, the growing, it feels like, incidences of workplace violence stemming from patient behavior.
Thanks, Crystal. I think having the staff help have the conversation, and also having staff let you know what would make them feel safe is super helpful too. In the chat, Austin commented that they have a law enforcement officer dedicated to the ED 24/7, as well as a security department that is here if needed. That is awesome. What a great resource. Do we have anyone else that would like to share anything on this or any other topics related to our emergency department care and quality and patient experience? Okay, well, I'm not hearing any, so I'm gonna release you back to your day. I want to thank you so much for your time, your comments and your thoughts and perspectives. It's incredibly helpful, and I hope that we can use that to help build some resources, even if it's just a menu of ideas, to help support hospitals in these different aspects of the patient care experience in our emergency departments. Thank you so much. Oh, my bad. I thought I had my email address in there. I don't. It's jwagner@convergencehealth.org, and I will put it in the chat. There we go. So again, thank you, everyone. I appreciate your sharing. I appreciate your conversations. Thank you for the great work that you do in your hospitals, trying to overcome these barriers every day. It is noted, it is appreciated, and it is seen. So have a wonderful afternoon, and I appreciate your time. Thank you.